how to measure the unmeasurable. Quantifying consciousness in the ICU can be a real challenge. Basically, my take-home message here is that when we try to capture consciousness at the bedside, we're basically making inferences based on the patient's motor responsiveness. And so I think we should be very careful in front of patients in coma, after coma, where sometimes we consider them completely unconscious and what we used to call persistent vegetative state, in those patients who awaken yet remain without any sign of consciousness. I prefer, and with the European Academy of Neurology now, we refer to them as just being in an unresponsive wakefulness. So together with the Academy, both in Europe and in the US, we've been trying, and you see here the wonderful people who participated, and the leading force here is Olivia Gossery, and you have her email address. I would like to emphasize how important it is for us to not consider consciousness like we historically did as something that's there or not there. It's not binary. It's a continuum, and it's basically showing these two components that you see here in this now old paper, where we emphasize that there's the level of consciousness, and that is wakefulness that we capture simply by looking at eye opening. And then there's the content of consciousness, and that is awareness, where we'll be capturing this by asking patients to do something. So to evaluate their sensory perceptual awareness by asking them to respond to a simple command. And we see that this is gradual. You can be more or less awake. Patients in coma, as you know, can no longer be awakened. Similar to ourselves when we're in deep sleep or pharmacological coma, we are with a low level of wakefulness and hence with a very low level of awareness. And then we have this very strange dissociation we now call unresponsive wakefulness, so-called vegetative state, awakening without signs of awareness. And then very importantly, as we heard, we should try as quick as possible to identify patients who are minimally conscious, or maybe I should say minimally responsive. And then you all know locked-in syndrome, pseudocoma, where the brain is disconnected from all motor control. The diagnosis can be uncertain, and that has been repeatedly shown that for unresponsive wakefulness, what we used to call persistent vegetative state, if we're not careful, there is 30 to 40% of the patients actually in a minimally conscious state. And we just miss it when we don't use the adapted, validated scales. The best one around is the coma recovery scale, and we should repeat that scale about at least 5 times. Now, this is a great tool, but it is time-consuming to learn and then to deploy in ICU, and that is why I'm afraid the vast majority of those now listening don't use the coma recovery scale. And so here is the scale we all know and use, the Glasgow Coma Scale, which is great, but it is a coma scale. It is not adapted to identify the minimally conscious state, which is something that you see in the ICU. So we said already, first component, eye opening, capturing the level of consciousness, that's arousal. Simply looking at eye opening. Verbal response, as we all know, a big challenge. Many of the patients are intubated, and then we lose one of the 3 components capturing awareness. Motor response, very important, very informative. Again, looking at awareness by looking for signs of command following, and then if it's absent, localization to pain. I'll here propose a new scale that I hope will be as simple to use as the Glasgow Coma Scale, but that will give us clinicians the sensitivity and the specificity of the coma recovery scale. You see it here. First, again, and we all do that, we look for command following. But it is made very explicit. There's 3 commands, 10 seconds between the commands, and if you have a response, at least 2 out of 3, you get score 6. Then you look for communication, which is of course very important. Functional communication gives the patients the right for autonomy. Terribly important when discussing treatment options and of life decisions. So again, it's made very explicit. Questions about where you are, permitting you to assess whether this is just intentional or truly functional. Following is looking for oriented behavior, something that is not part of the Glasgow Coma Scale, as is the assessment of communication. So we should look for patients grabbing sheets, holding the bed, scratching, but also, and importantly, whether they're different when their family's in the room. Do they smile? Do they cry for specific contents? Then they would get a score of 5. Also not present in the Glasgow Coma Scale is looking for visual pursuit or fixation. And we will do that here using a mirror, because that captures patients' attention. And again, it's made very explicit how to do it and when to score. Following pain localization, we all do that, we know it. And then finally, arousal, similar to the Glasgow Coma Scale. So very simple, very quick scale, but with the correct items, permitting not just to look at coma, but also unresponsive wakefulness, and as soon as possible, identifying minimally conscious state and emergence with the recovery of consciousness. So a scale from 0 to 8, 0 is coma, 1 is unresponsive wakefulness, what you use to call for vegetative state. Minimally conscious state minus non-reflex behaviors, 2 to 5. Minimally conscious state plus response to command, score 6 or 7, and then emergence from the minimally conscious state with the recovery of consciousness, score 8. Terribly simple. You have the references. Please contact us. There's also a paper by Leandro Sanz showing a video on how to do this. So, wrapping it up, when patients survive their coma, open their eyes, but it's only reflex movements, they're vegetative and responsive. Then we should really increase our efforts to identify signs of awareness. And that is first non-reflex movements, and they're made very explicit in the new scale, the seconds or response to command. When we have that, we can look for signs of functional communication, giving back patients their right for autonomy, something terribly important, of course, in the ICU. I thank you for your attention. I thank the whole team, the European Academy of Neurology. You can find in the guidelines how they strongly recommend to use adapted validated scales, and how they strongly recommend we should look for visual pursuit and doing it with a mirror, as it made explicit in the seconds. Thank you for your attention. Contact us for further information. See you next year, hopefully not virtual, but in Brussels. Cheers.